So I want to get into talking about mental health stuff vis-a-vis clients a little bit more between now and when we take our lunch at 12:30. So, you know, I have sort of non-traditional mental health training. I did my master's in holistic mental health, and I think it's really helpful to try to take an intersectional point of view towards the clients that we're working with that are dealing with mental health issues or substance use issues or both. So, you know, really making a point to see a human being and not reducing the person to a diagnosis or their history. I think it can be really tempting because it's easier to change an individual sometimes than it is to change a context, that we can over-focus on individual behaviors and that those role in people's health and mental health. And so really being able to zoom out and sort of look at family, culture, community, and systemic pieces that contribute to someone's health and quality of life. I know you all are probably pretty well versed in social determinants of health. And I think that, you know, that's a step, but I would, you know, take it even farther. Recognizing that oppression and inequality are some of the root causes of addiction, chronic disease, and many, many, many mental health symptoms. So it's not that the medical model is not useful, it's just that it's part of the story. Emphasizing that we all as human beings have common challenges and less than perfect coping skills, so that we don't sort of separate ourselves from clients with them as being people with problems and us being as people who help, because we're both. Avoiding trying to fix people or take responsibility for saving people from themselves. I think some of us are more vulnerable to that temptation than others. I literally own a little superhero cape because I mentally put it on and, you know, used to really create a lot of problems swooping in. And one of my friends got me one as a birthday gift. So I have it, and I sometimes wear it when I cook, and then I take it off and put it away because it's not, while gratifying in some ways, it's not really a sustainable way to approach the work. I think thinking about the complexity and the nuance of who our clients are and how they get to be where they're at helps us just be more flexible and sit with how uncomfortable it is to not be able to solve problems and not be able to prevent suffering. And sometimes all we can do is witness suffering and not be able to make it stop, and that's hard. And to me, this framework also is, we believe that change is possible, even if there's a lot of evidence to the contrary, and even if somebody's been stuck for a long time. If we get to the point where we don't believe that something can happen, the chances that that person will take those steps or let us be part of their journey, not so likely. So just, I think also this just fits with principles of doing care coordination well. So in terms of mental health, I think I would like for you to talk about what you're seeing, but at your table. So if everybody could mix up your table. So get up and move to a different table, not with the people you're sitting with now. And once you're resettled, make sure there's at least 4 people at your table. And I'm going to give you just a few minutes to talk about some of the questions that are up here. You can stay where you are just as we discussed for a minute. So I did a little bit of spying on tables just to get a sense, because I don't really know what the issues are, you know, here in Vermont. And I heard a number of conversations about working with patients with schizophrenia and other kind of delusional stuff that's challenging. A lot about both healthcare and mental health care for folks who are homeless, working, providing care and the challenges for refugees and their kids, working with people who are elderly and isolated and may not think that they have a mental health issue. The community mental health system just not having the resource that it needs to provide the care that people need, and the lack of follow-up. So people may have hospitalizations and then be sort of set loose without the kind of wraparound services that they may need. Some stuff about stigma and also just barriers around transportation, even for people who want to access care, can be really an issue. Are there other things that came up in their conversations that's important just to name in terms of context kind of issues? Yeah.
Poor communication between care agencies or care groups. So communications in every direction between the caregivers, the patient, and the organizations providing care.
Yes, huge issue, especially when the care is complicated. There are a lot of different players. We're going to spend a chunk of time talking tomorrow about how to try to make that madness a little more workable. Other issues that folks have raised that we haven't named yet?
Just a lot of clients with anxiety and depression.
Yeah.
It's huge.
Yeah, usually when I do a mental health 101, we do anxiety, depression, and PTSD, because those are the three things that I see the most. There are other things that happen, but I feel like you probably, if you're looking at folks that are dealing with health issues, at least a third are dealing with either depression or anxiety, either that came before or that came as a result of chronic disease, living with a chronic disease. Good. Anything else folks want to add before we proceed? Yeah.
I think what we were talking about is releases, because we and a lot of organizations are pulling teams together now around some of our clients and patients, and trying to get a universal release is really difficult. The mental health release seems to be all by itself, where the rest of the organizations can be listed on a release. Mental health stands alone, so that's a challenge.
Absolutely.
We talked to them about just the confusion or lack of clarity around where mental health diagnoses come from, how they get documented, how they carry over forever and ever and ever, and it can be confusing how that's linked to current care or like active needs.
But sometimes it is and sometimes it isn't. And sometimes it is in a way that fits where somebody was 20 years ago when they got a diagnosis and has nothing to do with where they are currently. Absolutely challenging. Good. Good, good. So it's just a little bit of the lay of the land here. I think this thing is actually, yeah. So some common challenges. Stigma, I think, is, in my opinion, the biggest barrier to accessing services. That mental health is one of the only areas where people get blamed for what's going on with them, and that often the providers are not particularly, the systems are not competent to care for the behaviors that people who have the issues exhibit. And so it goes around and around the mulberry bush. I think because healing and dealing with mental health issues is a long-term process, the systems of care are not set up to sort of accompany over the long term. Certainly the systems have problems unto themselves. Most of the clients that I see and that the teams I work with see also just are dealing with multiple chronic stresses and barriers that make, if you were housed and had a reliable income and transportation, maybe your depression would be manageable. But when you take those other things away, it gets exponentially more complex. Again, I don't know how it is in Vermont, but what I've seen in Massachusetts is funding for especially outside the medical sector for nonprofits is less and less and less. And so there's mergers and agencies closing and people being expected to do a lot more with fewer resources, and the reporting requirements are not decreasing. So it's a whole larger system under stress as well. I think also in my experience, clients that have mental health issues are more triggering for staff because often they're acting out, they can't manage themselves well, they can cross boundaries. There's a lot of stuff that makes this population, even in its diversity, more challenging to work with. And I think too, knowing that there are these larger contextual factors like income inequality, sexism, structural racism, the effect of war on drugs, and so forth, that impact people's mental health. And those are things that are big and entrenched and difficult to change. And so it can be sometimes demoralizing to look at the way the larger factors are impacting an individual person's life. I know I feel powerless sometimes because I look at the person and I think it's not a person who has a problem. I mean, a person is displaying behaviors, but they have a problem that's about a much larger problem that I don't always know how to engage with. So I want to offer this resource to you all, and we're going to spend some time over today and tomorrow practicing with it. So I brought one copy of the actual book, which I will pass around. But basically, what I have heard again and again from folks is we have people with mental health issues that want to see a therapist. We have people with substance use issues who don't think they have a drug and alcohol problem, who don't want to get treatment. And we're trying to help them with housing. We're trying to help them with healthcare. We're trying to help them get stabilized. What do we do? Because you can make the therapy referral 25 times, and it doesn't mean the person feels comfortable, that they have access, that they're going to follow up, and so forth. So we put a team of people together. We had a grant from the Blue Cross Foundation. That's a typo. It was not in 2103. To reduce health disparities in the state of Massachusetts. And so we created, it was some community health workers, social workers, some public health people, primary care doctors, including some addiction specialists, and a couple of psychiatrists put this curriculum together. So we started with harm reduction and motivational interviewing, a strengths perspective, and tried to draw on practices from holistic health and kind of an integrated view of a human being in putting this thing together. So it is, it's free, it's open source, so you can take it, use it, share it, do whatever you want with it. We have a couple of groups that are using it in a more structured way. So there's a community health worker team, a couple teams in New York City and Boston that work with people with HIV that use this curriculum, and then a team in Los Angeles and a team in Arkansas that work with people with chronic diseases that are using it currently. So the goal of this thing is to try to build staff skill and knowledge around mental health and substance use and how to work with those things together and separately. So think about how we educate and empower the people that we work with around their self-management of these issues. Trying to help people get more ready to go to care. So if they have, 25 pieces of misinformation about psych meds, it's worthwhile to have a conversation and try to uncover some of that and do some appropriate education. But really thinking about how do we decrease stigma and increase people's coping skills. So the link to download the curriculum is there. It's on PCDC's kind of resource page. And you all have a few sections in your folders that we will be using for our practices. Questions or comments about that? I will pass this around and you can take a look at it. This is the one that lives on my desk at home. So the way this thing is set up, it has 3 tracks. So there's a mental health track, there's a substance use track. You notice it says substance use and not abuse because it's meant to be used with anybody who drugs and alcohol in some way are part of their life. And there's a dual diagnosis track. So the chapters have an order that's intentional. So we sort of start with, tell me about your relationship with being depressed, or tell me about your relationship with smoking crack, and build from there. But if you're working with someone who's like, I don't want to talk about meds, I don't want to talk about treatment, but I do want to talk about stress management and spirituality, you can just skip ahead to the things that an individual person would want to work with. So each topic has conversations in it, usually between 2 and 3, and each conversation has a little bit of teaching content and then some activities. And they're designed to take about 20 minutes to do as part of a visit. So people do these sometimes on clinic visits and sometimes on home visits. There are priority and optional topics. So the priority ones are recommended to do with everyone, and then the optional ones, I'm trying to think what's an optional one. I think the spiritual coping is an optional one. So if you have someone who's like, I'm not religious, I'm not spiritual, I don't want to talk about that, you can skip it. It's not a script. So, when I started, I've worked for this program, this HIV program called PACT in Boston for a bunch of years, and they're really into curriculum, and I was kind of like, curriculum, it's like it's staying in a binder, it sits on the shelf, what are you going to do with that, really? I was not persuaded, and it took me a while both getting trained and then using the curriculum to sort of see the benefits of it, and I definitely have come around to just recognizing that we all have our own ways of working with people, and that we're good at some things and less good at others, and that it's really easy to get stuck in a rut of what we know how to do. And that one of the virtues of having a curriculum is it helps us try different things. And even if you're like, wow, that didn't work, it shifts us sort of out of our habitual ways of working with people into doing something else, which is usually beneficial. So it's not a script. You don't pick it up and read it. It's meant to be a jumping off point for a conversation, or a framework to just help you go deeper with somebody that you're working with. So facilitating conversation, uncovering barriers, helping you and your client better understand what actual motivation is there, and then moving from reflecting into action. So each chapter has images and metaphors, just because I think, something like, how do you explain how psych meds work? we're like, we want to write that in a way that assumes people don't have a ton of health literacy at their disposal. And so it's, you know, pictures and metaphors, and think of it like a power plant, and here's a picture of a neurotransmitter. So there's accessible stuff in there. Little bits and pieces of psychoeducation, some wellness activities. I am a big fan of expressive arts, so there's collage, journaling, other kinds of things. And I have some clients that are like, woohoo, bring it on, and others who are like, do not bring a glue stick to this meeting. Okay, that's fine. And then if if you're more of the like planning, organizing, there's a lot of different kinds of organizational tools, worksheets, and so forth that are in there. So, comments or questions so far? This is sort of like a rundown of what's in here. So I want to give you kind of a tour of the tools and resources that are in there and a chance to practice with them, as well as some opportunities to apply this kind of material to some different kinds of clients and just see how it feels and kind of how help you get comfortable doing this for yourself, as well as how do you adapt it to different kinds of clients. So I think, let me just see where I am here. Time. Is there a folder for me so I can just see what we've got in there? So what I would like, so our next activity is a role play and a practice using the curriculum. And I wonder if it would be helpful for you all to see a demonstration kind of how we imagine this being used. Should we do that briefly before I ask you to do it yourselves?
Sure. Okay,
cool. So let me just see, where are my chapters here? So if you will look in the left-hand tab, where's my curriculum pages? Okay.
Just order it online.
So if folks can pull out, there are two things here. There's one thing that says how to use this guide, and there's one thing that says why me, and it's just a couple of pages.
May I?
Yeah, you can go back to where you're sitting before if that makes you feel more comfortable.
Or you're going back to your
So this how to use this guide is just a little section in the front. It's about halfway through the left-hand tab. And I just wanted you all to have this kind of framework in terms of how do you actually put this material into practice. So there's stuff about methods, using your motivational interviewing, putting things in your own words, checking in with the client to see what they're interested in, what they understand. So a lot of the stuff that you all learned in your original care coordination model certainly apply to how you use this material. And the second piece of how to use this guide is using curriculum with special populations, because I think how you use it really depends on the person who's in front of you. So there are some recommendations if you're working with someone with cognitive issues, clients who are in crisis, clients who come in drunk or high, clients who don't think that they have a problem, and so forth. So this is really a resource when you think about how to use it, and if you have questions. Okay, so that is that. So the thing I want to do the demo practice with is this little piece called Why Me? And it's purple, which means it's a dual diagnosis conversation, which means, which one did I pick here? So I picked the mental health one because we're in the mental health section. So the way this thing is set up, there's sort of a cheat page at the beginning of every chapter. And it says basically, who would you want to do this topic with? What are the goals of the topic? What do you need to do to get ready? So there may be something you need to read or a tool that you need to get familiar with. And then there's a breakdown of what are the conversations and what are the activities. So everybody see this? It says page 19 at the bottom, why me? So this is an early chapter and it's a pretty straightforward one, just so you get a sense of how this thing is set up. So if I were going to use this in an appointment with a client, I would read it through beforehand. And I might just decide I was going to go in order, or if a particular topic came up like, let's say somebody just got a diagnosis of bipolar disorder, and they're like, I don't know what this means, I don't know what to do with it, why is this happening to me? You might say, this would be a good time to have the why me conversation. So is there anybody who would be willing to be a client be one of your clients or someone, you know, the client of someone that you supervise who has a mental health diagnosis and maybe is wanting to talk about it a little bit? Can you think of a client of your own that fits that bill? All right, I can't do a demo if no one volunteers, so that's fine. If you don't need a demo, then I won't do one.
I'll do a demo.
Thank you. So just come on down. And this is going to be brief, so.
Do I have to?
Nice deal from you? Yeah. Oh, yeah. Well, yeah, no, you're going to be the client. And so my goal with using this, if we look at this stuff, so the why me topic that we have here is just about talking to the person about, why do I have this diagnosis? Where did it come from? What does it mean? Why did it happen to me and not to somebody else? So if I knew that I wanted to have this conversation, I'm going to ask you just a little bit about this client. I would look over my notes here. So talking about genetic factors, talking about environmental factors, talking about personal history. So I would just go through and review the blurbs. And there's a little thing that sort of says say, ask, and you don't have to read it. You would put it in your own words. Definitely not, and definitely don't be reading a piece of paper. So ideally you read it, you review it, you take it and use it in whatever way works for you. And then there's an activity, which I'm not going to do with this client, but I'll sort of meet us there. So just tell me a little bit about who are you?
Who am I?
Yeah, you just don't tell me your actual name, but like a little bit of the client background.
So I'm a professional person and I deal with the public, but when I'm home, I really don't. Use the microphone.
Yeah, can you use the mic?
Oh, when I'm home? No.
Can you turn the volume up a little bit?
Okay. I'm a professional person, and I own my own business, and I work with the public, and I deal with the people in the public. When I get home, that's not really what I want to do. I just want to be left alone. I want to be quiet. I don't want anybody talking to me. I don't want you moving in the house.
Okay, and do you have a mental health diagnosis?
No, I'm
Okay.
fine. I'm fine.
Do you, in your chart, have a mental health diagnosis?
Yes.
I need someone
Yes.
who's willing to at least go there a little bit.
Yes.
Okay, and what is it?
The doctor thinks I'm depressed.
Okay, but you don't think you're depressed?
No.
And did you receive this diagnosis and like this is known to you that your doctor thinks you're depressed?
Yes.
Okay. Okay, and what should I call you?
What should you call me?
Yeah.
Depressed.
No, what should I call you by name?
Oh, you can call me Charlie.
Okay. Great. So can you hold the mic? Is that totally weird?
Yeah, it's really weird. I don't think I do this in the doctor's office, would I? No.
No, definitely not with the microphone. Okay. So, hi Charlie, thanks for coming in to see me today. How are you?
I'm okay.
Yeah, how have things been going at your house? I know you've been kind of wanting a little peace and quiet.
So nobody listens to me. There's all this noise and all the stuff that's happening, and I'm just sick of it. And I just want to be left alone. So I go upstairs into my room and I just close the door and stay there.
Got it. So you've been sort of hiding out from all the people.
Well, they won't be quiet.
Yeah. And is this getting to you more now than it has in the past?
I think so.
Fair enough. So I know, so you know that I talked with your doctor because we're sort of part of the team together, and what she told me is that she thinks that you're depressed. I don't know what you think about that.
No, I think I'm just tired.
Tired? Yeah. Well, so tell me a little bit about tired. What's that like?
So I just feel like I want to sleep all the time.
Mm-hmm.
I feel like I just want to rest all the time when I'm not around others. I really don't want to be around others if I don't have to be.
Mm-hmm. So you're more comfortable being by yourself and wanting to rest more than before.
Yes.
Got it. So if we were not doing a role play, I would totally pull out the depression education chapter and start talking about signs and symptoms of depression and how would you know and how do you know if it's depression or something else. But that's not what we're doing. So just a caveat. So will you, just for the purposes of me being able to demonstrate the curriculum, be willing to entertain the idea that maybe you're depressed?
Yes.
Okay, cool, artificial, but just for the purposes of practice. So, would it be okay if we talk a little bit more about depression right now?
Okay.
Thanks. So I think, one of the things I hear a lot from people when they get a diagnosis is sort of like, is this right? Does this apply to me? I'm not sure. But, there are a lot of different factors that contribute to somebody getting a mental health diagnosis. And I wonder if it would be okay for us to talk about that a little bit right now.
Okay.
So, some of it is genetic. So mental health issues like depression, anxiety often run in families. So you see, if your parents dealt with depression, it may be more likely that you will also.
My mother and father did, yes. They
Both
did.
of them?
Yes, they did.
Can you tell me a little bit more about that?
So my father was severe depression and ended up with dementia.
Oh, wow.
My mother was severely depressed but never really believed it.
Mm-hmm.
And then when my father died, my mother didn't believe that she was depressed, but her provider talked her into medication.
And what was the effect of the medication?
She became a little more social and
Okay.
a little bit better.
Okay, so even though she didn't think she was depressed, she agreed to take the medicine and she was a little better because of it?
Under duress.
Okay. Okay, so depression runs in your family.
Yes.
I think that's pretty common. I think too, there's another piece which is environmental stress. So a lot of times if you have this family history, that puts you more at risk for depression and something happens in your environment. So it could be, chronic stress, it could be the loss of a job, it could be a health issue or something in your family. That will be the thing that sort of kicks you from I'm stressed out but I'm okay into I'm having the symptoms and suffering with depression. I don't know if that makes sense for you with where you are now.
So I think it's family drama, I just don't want to deal with it.
Okay,
So
so family
I don't
drama
wanna hear
is
it.
a potential trigger for you.
It is.
Okay, fair enough.
I don't understand why they can't control their own lives.
So it creates stress for you dealing with the stuff that's going on with the rest of the family.
It does.
Fair enough. So another piece, I think, of what contributes to depression is just our personal history. So if we've had losses, really difficult things happen in the past, especially in childhood, those are the things that you kind of, you put it in a box, you leave it alone, you get on with what you got to do, but that can kind of come back, and that can be one of the underlying things that contributes to being depressed. Now, I have a little one. So I don't know, what you think about that, if there's stuff that you think of from your past that could be a factor in you feeling depressed now, or just feeling like you don't want to deal.
So I come from a large family, and my dad used to disappear, just disappear out of the blue, be gone, and then
Like
come
disappear in
back.
the house or disappear in the world?
Just disappear. We never knew where he was.
Oh, wow.
And he would just be gone and maybe come back a week later.
Wow. Well, so when your dad was gone, what happened?
We were pretty afraid, and Mom had to take care of everything, so we were just pretty afraid of where he was and what he was doing and if he was ever coming back.
Got it. Well, it sounds like there's a lot to talk about in terms of that. Just, what happens when you're a kid and you don't know
But that's
where your
normal.
dad is.
Everybody has that stuff.
For sure. I mean, I think everybody has weird stuff that happens in their family, but it does have an effect even after the fact. That's, I think, the interesting thing about the way human beings were made. So I wondered, the activity that I was thinking about for today, and you tell me if this makes sense for you, is that we do a little mapping about your family, because I think if we understand sort of the things that run in the family and who the different players are, it kind of gives us a better sense of kind of what you've dealt with and what you might be inheriting. So if it feels comfortable to you, we can sit down and just do a little drawing about sort of who are the people in your immediate family and then what their mental health situation has been. What do you think about that?
That might be interesting.
Okay. Pause. Thank you very much.
You're welcome.
So, y'all can see, I'm gonna, just pass this back to you. I didn't sit here and read this thing as if it was a script. There was a little pieces of psychoeducation that I wanted to offer to Charlie, based on, what was going on in that situation. And then I was trying to present it in a way that both sort of draws on the motivational interviewing, so the open questions, the reflecting back, what I've heard, and then a lot of checking in, because I think one of the things that's hard for folks with mental health issues is you feel like you lose control pretty easily, that you get a label and someone has a medication and a treatment, and the next thing you know, the train has left the station. So I think being able to move slowly and help people kind of think things through bit by bit and understand pieces of the information is really helpful. So questions or comments specifically about sort of how to use curriculum in this model? Or anything that you saw in the role play that you were like, what was that?
Okay, I'll just talk.
I like the idea of the mapping. I think that's a good idea, to be able to put it down and be able to see it. Because I feel that if people that are in denial, if there's something concrete that they can see and feel and touch and talk about, they consider it better.
Absolutely. Well, I think for some people, just being able to draw and to look at things visually. Also, I mean, the thing I hear so much from people is, I'm normal, I'm fine, there's nothing wrong with me. And I think you can affirm that there's nothing wrong with someone and they're dealing with a mental health issue, and both of those things can be true. So for someone like that, it's like, yeah, if you had 2 depressed parents, what are the chances you're going to come out of that situation and not have to deal with depression in some way? And to name that and to normalize it, I think is really important. Other comments or questions? Because I'm going to throw you into doing your own practice here next. So if there's anything you need to know to feel ready, ask. Yes?
I love this idea. This is very helpful to me. My question is there any guide as far as if you start tapping into some of this stuff, some of the dangers that could be if you trigger someone and they start really getting into the activity, how to kind of, now you're sitting there with a client or a patient that is losing it,
Yeah.
and how to kind of make them okay to leave.
Mm-hmm. I mean, I think a couple of things. So when she started talking about dad being gone, if I were her therapist, we would have gone there. But in a role, an accompaniment role, it's something I would name and then sort of say, that would be a really good thing for you to bring to your therapist or your counselor at church or wherever it is that you get more support. I think too, the asking permission piece is really important, because people usually, if it's something that's really uncomfortable, you say, can we talk about your depression? They may just say, we're not going there. And if they start to get upset, I will sometimes check in and just be like, is this okay for you? Are you feeling overwhelmed? And if it is, we may change what we're doing. And if they're like, no, it's okay, you just want to make sure, if you have a half hour with someone and you're at 25 minutes and they're crying, you either need to extend the appointment or you need to find a way to kind of move up to something safe before you send them out. I think it's a really important point, and we should continue to think about that. Yeah. I think the mic will come to you.
So the question there at the end is really important, I think, to recap. So when you were saying, when she brought up this issue about the father being away, just reinforcing those initiatives, I think, at the end, or checking in with the patient to make sure that's what they want to work on next. Or I'm just wondering, how would you wrap up a meeting like that? I'm thinking summary.
Yeah, I mean, for sure. We would need more time, but I think, sort of summarizing. And I think too, if I'm not sure what to do, usually I'll ask the client, like, what feels important to you today? What do you want to talk about? What's uncomfortable? And really trust and go with that. And it may be that there are things you don't get to for a while until the person is ready, and that's totally cool. So I want to move us into practicing, just so you get a chance to try this out for yourselves. So what I would like you to do, we're going to break into pairs, and if the pairs can spread out a little bit so you're not distracted by other people who are talking. So what I want you to do, you're going to have about 8 minutes to practice a visit. And so I want you to use your motivational interviewing skills. So thinking about asking the open questions, giving affirmations as appropriate, reflecting back what you've heard, and summarizing. And we have two clients. Let me just pull them out. So they're in the, I don't know how this thing is arranged, so we got to figure it out together here. Yeah, so there's a handout on the left tab that says care coordination cases for practice, and there are 2 mental health cases. So the person in your pair with the shorter hair is going to be the client first. So everybody found this page. It has 2 bullets on it and says mental health cases. It's about halfway through the left tab before you get into the curriculum sections. All right, so does everybody have that page? Okay. So, yeah, and if you don't, we'll find it for you. So let me just walk you through this. So the person with the shorter hair in your pair is going to be the client first, so that person will be Mike. And the person with the longer hair, when we switch roles, will be Carlene. So what you have on this paper is a description of the client, his situation, strengths, challenges, kind of what's going on, so that you know how to play him. And the person who is interviewing and working with him, you're going to use the curriculum called Managing My Health. And that's pages 126 to 128, and it's in that packet. And your goal with Mike is to help him look at how his anxiety is impacting the rest of his life. And there's a little worksheet in that section that you're going to use. That's you. Yeah, so we have these extra chairs, and you can feel free to spread out. So, yeah, this practice is a little complex, and I hope that it will make sense to you. So that will be the first round, and then I'll ring the bell, and then you're going to switch roles. So whoever was doing the interviewing is going to then be the client, and the second client is Carlene. And the person who's going to interview her will use the pages called Ready for Treatment, which is pages 136 to 138. And you're wanting to talk to her about what kind of mental health treatment she's ready for. So what I would like you to do now is find a partner, ideally someone you haven't worked with yet, and then just figure out whose hair is shorter. And usually that's easier when there are men or women with crazy haircuts in the room. So you may have to estimate. And make sure that you each have the material you're going to use, and see if you have any questions, and then we'll give you the green light to go. So it looks like I floated around and did a little eavesdropping, and it looked like some folks were really rolling, and other folks were struggling a little bit more. So can you just hear from a few people, how was that? How did that go? Hard. Straightforward.
It was hard to not ask. It was hard to be mindful to continuously ask the open-ended questions. I'm not that experienced in motivational interviewing, but just really having to step back and then trying not to propose the solutions. That was the other thing, is asking the open-ended questions, and then just catching myself and not being afraid to rephrase my questions while midstream, and then asking the patient client for what are their ideas. And I did more steering of the conversation than I should have, I think. So, but it was hard, is all I can say.
I mean, I love the self-awareness there, that it's easy to catch yourself asking closed questions, and it's like, okay, how do I rephrase that to make it more client-centered? I noticed as well that folks are really good problem solvers, and so you had ideas about what this client could do to handle himself, and referrals and medication and all kinds of stuff, and that is really great. And it's not what a motivational interviewing approach asks us to do, which is much more about exploration and understanding and helping the person solve their own problem through a series of conversations over time. Other folks, what went well or what was challenging from your practice?
My partner did the active listening really well. I think that it can come off as condescending, where people are like, oh, what I heard you say was, and then they repeat verbatim what you said, or they
Yeah.
do a lot of the, You kind of feel like they're not listening, but
It can feel like bad therapy, right?
Yeah, but she was able to reword it in such a way that it showed that she was listening, but it wasn't condescending.
Awesome. So there's something about the genuineness of that that's really important. If it feels fake or it feels like a technique, it really turns people off. And that's why we practice here as opposed to go practice on clients, right? There's another hand over here.
I think one thing that was, so I was Mike, the guy who was the recovery guy, and she was asking me so many questions, and I was feeling like when I talk to my patients, some of them, their lives are just so complicated and so hard and so depressing that it sounded awful. And I wonder if my patients feel that way when they're talking to me and they're being so open and sharing so much.
It sounds like you feel kind of like both vulnerable and overwhelming.
Yeah.
Yeah, I think it's really good to be mindful about how many questions we ask and how, kind of, you got to earn the right to ask those questions over time.
Maybe a shorter agenda or a shorter.
Yeah, well, I think too, it's one of the reasons, I think if I hadn't gone into counseling, I probably would have been like a journalist, because I love asking questions, and people would, come in and meet with me and they're like, oh my God, I feel like I've been through a grueling interview. And I was like, I have to find another way to talk with people. And so doing the reflections actually has helped me back away from asking so many questions. Because if you do a good reflection, the person will keep talking and tell you more, and you don't actually have to be like, tell me about blah, 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 and what about this? So I think it makes it sometimes a little less overwhelming. We'll talk about that more. Yeah, go ahead.
I think being Mike, if you get into the role, hearing someone actually ask your permission to go to a certain place is really helpful. And I also think that having like the paragraph of this description of Mike's life, picking up on having the person who's doing the interviewing, picking up on the fact that music is a positive thing, and kind of how you can, if you can bring that out of a kind of a depressed mode of just, you can't help but smile when you think of something that makes you happy.
Yeah.
And kind of how can you make that part of your current life in a different setting. It just changes, it shifts things a little bit. And I think that's really helpful to have someone ask for permission and pick up on even the slightest word that is positive to change the frame.
That's awesome. I think you really did a nice job of articulating what is the gift of taking a strengths perspective, is that we're really good at honing in on problems and the complexity of the problems and how to fix the problems. And everybody has strengths and joys, even if it's something from the past or something distant. And if we can bring those into the conversation, it's one of the places that life energy comes from, that something positive can actually happen, even if it's something small. Thanks. Good, so I would like to take our lunch break now and do the other role play after lunch. Is that okay with everyone? I feel like we've had a good morning. So we have an hour and 15 minutes for lunch. I've been told either that you need to wander or that you don't want to rush the lunchtime. So if you don't know where to go, I think we have some staff here that can make recommendations, and just encourage you, if you are over people, to have a quiet lunch, and if you would like to socialize, just have lunch with some people, because it's a nice chance to talk. So we will get going again at 1:45. Sorry, 1:45. 1:45. Okay? So again, I would love to hear from folks. It seemed like this, I'm not sure how this went compared to the other, if you all are getting sort of more comfortable with this flow, or whether there were things about the content that made it harder to engage with maybe than what we did earlier. So how did that go for folks?
I thought it went well for us because she has had experience. She's a tobacco treatment specialist, so she already does it. And so when she did that part and I was the patient, it went a lot smoother.
So easier if you have some competency to build on already. Good. How about other folks? I'm happy to hear from it didn't go well, and this is why too. Anybody that we haven't heard from want to share anything?
This isn't really about what we talked about. It's just as being the patient, and this one really made me realize how different it is from the more medical model, and like going to the doctor's office and as a patient, and how those questions are so different, and how you really get more to what's really going on for a person with this type of conversation.
Mm-hmm. Thank you. It's a different paradigm that requires both a different approach and ideally yields some different responses. Anybody else? Easy, hard, relevant, not relevant?
I don't like the true false thing.
Yeah, say more.
I just don't like it. I wouldn't put my, never in my life have I ever had to use my.
I just didn't like, so I was the interviewer in this one, and I didn't like, I wouldn't like to say to a patient to answer something true or false. It feels very, test-like, like investigating, like gleaning more information about you, as opposed to when you're doing motivational interviewing. I mean, you have more of a back and forth.
Yes.
You know, this, and when we started, I was like, you know, we just couldn't even get like rolling with it. I just didn't.
A harder way to sort of enter into the
harder way to, and less room for.
When we've done this, we've actually done it as a game before. So, you have to have the right kind of patient to be able to have the conversation. So it may be that you read the myths and facts, and when it comes up organically in conversation, you're like, okay, I know actually myself what the accurate information is, and so you can bring it in as needed. Or I've sometimes approached it as a kind of like, let's learn this together. Because I mean, I hear all kinds of stuff from clients all the time about their psych meds, and I sometimes don't know even myself. You know, people say, oh, I take this med and I gain weight. It may actually be true. It's maybe not generally true, but if you frame it not as an I'm testing your knowledge, but more, let's try to learn about this together, I think it has a different flavor to it.
Yeah, I mean, we were just sort of saying, like, the first question is, like, when you get addicted to psych meds, well, if you tell my patient who ran out of benzocaine that you can, she's going to tell you she went through withdrawals. You know, so like,
it's more
that would be
complicated.
a hard way to start that conversation with her.
Fair enough. Thank you. Yeah, go ahead.
I agree with that, and I also feel like you're setting someone up to be wrong. But we do a lot of group programming, and I almost think this would be perfect in a group programming setting. You know, we do like Medicare bingo, where we ask Medicare questions.
Yes.
And so you could almost do this with a group setting where people keep track of their own answers, and then you review them together, so that way they still get the information.
Yep.
But nobody has to know that they got the question wrong.
That's a fabulous
that would be
idea.
really good.
So we've had a couple of programs approach us about turning this curriculum into group modules, and I have not done that, but should you feel inspired to do that, a lot of the activities actually I think would work better with a group of people rather than doing them one-on-one. So thank you for that suggestion. Anybody else have anything you want to add before we sort of change speeds, change topics? So this was a pretty quick sort of crash conversation around mental health stuff, and please continue to raise questions and comments as we go, because it's not like we're gonna leave the mental health stuff out as we transition to talking about substance use, but we're gonna move from there, unless anybody has anything else they need to say. Okay.